Okay. She is interested in the interplay between biologies such as sex hormones, body composition, energy metabolism, and sociocultural influences on differences and disparities in diabetes. More recently, she also studied the sex differences in COVID-19, leveraging large real-world databases. Yilin Yoshida completed a 2-year postdoctoral fellowship in the Department of Health Management and Informatics at Missouri University. All right. Prior to that, she received her PhD from LSU School of Public Health with dual concentrations in community health and behavioral sciences, and also epidemiology. She received her Master's of Public Health from Tulane School of Public Health and Tropical Medicine. And today she will discuss sex differences in the risk of cardiovascular disease associated with diabetes. Dr. Yoshida, thanks so much for being here, and take it away.
Thank you so much for the introduction, Megan. And thanks so much, guys, for being here, waiting us for a couple of minutes. We were using another link. So yes, my name is Yilin Yoshida. I'm an assistant professor in section of endocrinology and metabolism at Tulane School of Medicine. So today, I'm going to hopefully cover an interesting topic to you, the sex differences in cardiovascular risk with diabetes. Just like Megan introduced just now, that I received my graduate training in New Orleans, Louisiana, and then I complete a postdoctoral fellowship, focus on chronic disease epidemiology. I returned to Tulane in 2019, and then in the following year, I was awarded the Birch Scholarship. Just give a shout out to Birch program at Tulane, also LE-CATS pilot programs. Because through these 2 programs, I was able to gain collaboration and also mentorships from leading scientists in diabetes research. And they inspired me to sort of reconceptualize my research. Before I was really doing some behavioral social aspects of diabetes. Now I try to integrate more clinical and biological ingredients into my research. And hope to adopt a more comprehensive way to explain some of the sex and ethnic disparities in diabetes. So this is the outline of my talk. I think I will finish in 20 minutes so that we have a few minutes to discuss some of the problems or questions. So first, I will provide you an overview of the epidemiology of diabetes with a sex-specific perspective. Followed by women's disadvantage in cardiovascular complication in the context of diabetes. I spend most of the time to provide you several explanations of this sex disparity. So globally, there are more men diagnosed with diabetes, and the incidence rates rises with advancing ages in both sexes, reaching the highest rates in the very old women. And pre-diabetes measured by impaired glucose tolerance appear to be higher in women compared to men on a global scale. So in the United States, the adult population, so this is a data from the graph generated from NHANES data, which is the largest surveillance survey system in the US. We can see that, stratified by ethnicity and sex, in the non-Hispanic group, non-Hispanic white group, the last 2 bars, we see that more men develop with diabetes compared to women. And similarly, in the Asian group, the second set of bars, we see that more Asian men developed diabetes compared to Asian women. But in contrast, we see in the Hispanic groups, there are more women develop diabetes compared with men. So we know that diabetes is associated with a variety of complications, and the mortality in diabetes is not caused by diabetes per se, rather it's due to diabetic complications. And the most common cause of death in type 1 and type 2 diabetes is cardiovascular disease, CVD. So it is estimated that CVD accounted for more than half of the deaths in diabetes. Notably, there is a sex disparity in diabetic CVD, that is female patients facing a higher risk of both fatal and non-fatal CVD compared to male patients. And this is the pooled analysis results from more than 60 cohorts around the world by the year of 2014. And results showing that, so the the top rows, CHD, chronic heart disease, that is the presence of diabetes nearly triple the risk of incidence of chronic heart disease in women, whereas it's little more than double the risk in men. So look at the relative ratio between men and women. So this 1.44 means that diabetes confers 44% actual rates in terms of chronic heart disease in men compared to in women compared to men, and very similar findings presented with the outcome of stroke. That is, women facing a higher risk of stroke associated with diabetes compared to men. So our colleagues in Pennington also found out that the sex disparity of stroke in the context of diabetes. And using the patient record from the LSU healthcare system, they found that each 1% increase in baseline A1C was associated with a 5% higher relative risk of stroke in women compared to a 1% higher risk in men. So what are the reasons for this sex disparity in diabetic CVD? So the underpinning mechanisms are not fully understood, but some of the risks may be the result of women's poor management and treatments of diabetes. So historically, women with diabetes who are also with adverse cardiovascular risk profile were treated less aggressively compared to men. And women were also less likely to achieve the recommended level of risk factors. So despite a more equitable treatment access between men and women over the past 2 decades, especially in the high-income countries, the sex differences in medication use and risk factors control continue to exist. So in other words, treatments and management alone, they don't explain, at least not fully explain, the sex differences we're seeing in CVD in the context of diabetes. So more and more evidence suggests that the biological differences between men and women can be the real explanation for the diabetic CVD, the disadvantage of diabetic CVD in women. And many speculate that the greater deterioration in risk factors occurred more in women in the transition from normal glycemia to overt diabetes. And this graph showing you the sex differences in body anthropometry and fat deposition at the time of diagnosis, diabetes diagnosis. On the top row, you can see that at the time of diagnosis, women tend to put on more weight, and they tend to accumulate more fat in the abdominal area. So some research also suggested women tend to be more obese than men at the time of diagnosis. So as opposed to the lower row, the men, the middle figure. So at the time of the diagnosis, men tend to have a relatively normal weight gain, or they tend to have a relatively normal fat distribution. So women have a higher subcutaneous fat storage capacities, but when they reach to a higher BMI level and the subcutaneous storage is exhausted, women's fat is also placed in visceral and ectopic tissues. And the abdominal visceral fat in women has been found to have a stronger association with insulin resistance compared to men. So in summary, women face a much higher risk of weight gain and visceral adiposity at the time of diagnosis as opposed to men. So a population-based study in Scotland, and they found that the mean BMI at the time of diagnosis in men was nearly 32 compared to a higher BMI level in women, 34. And they also plot this figure on the right hand. That is this is a sex differences in BMI at the diagnosis by age groups. As you can see that the sex differences in BMI at diagnosis is marked in the younger age groups, and the gap is almost disappearing at the very old age groups. So not only adiposity changes are different between men and women before overt diabetes, The changes of other risk factors between those with and without diabetes is also greater in men in women than in men. So, and this is a table from a cross-sectional analysis based on 3 cohorts. So researchers using the baseline data to show that the mean differences between those with diabetes versus those without in terms of systolic blood pressure and HDL cholesterol. And they found the mean differences is greater in women compared to men. So we've seen several of this cross-sectional analysis based on the cohort baseline data and basically showing the similar results. However, it is unclear how the change of risk factors in the development of diabetes following the same group of people over time, and whether this deterioration in risk factors in the course of this disease development differs between sexes. So to answer these questions, so we conducted a cohort analysis using a well-characterized epidemiology study, the atherosclerosis risk in community study, the ARIC study. And we look beyond the individual risk factors. We included this continuous risk biomarker called the metabolic syndrome severity score, which derived from the common risk factors, including waist circumferences, triglycerides, systolic blood pressure, HDL, and fasting glucose. So what we found is that in the pre-diabetic state, look at these green bars. So women experience a faster or greater change in the metabolic syndrome severity compared to their male counterparts at the pre-diabetic state. And what also struck us is that even in the normal glycemia state, women experience a greater deterioration in metabolic syndrome severity compared to men. And this figure showing you the waist circumferences changes before over diabetes. So in line with the speculation that women put on more weight, especially in the abdominal area. So we confirmed that the increase in waist circumferences is greater in women relative to men in the pre-diabetic state and also normal glycemia state. So we now confirmed that women already have a worse cardiometabolic risk profile before the overt diabetes. So what else further explains the higher risk of diabetic CVD in women? So we know that around late 40s or early 50s, women experience menopause. And menopause is categorized by a decrease in endogenous production of estrogens, so which is associated with vascular dysfunction, increased blood pressure, obesity, and hyperlipidemia, and all which increase CVD risk. So there are also a group of women who encounter menopause earlier. That is, they encounter menopause 45 years old or earlier. And this group of people may experience earlier interruption of cardioprotection associated with estrogens. So we wonder that if it is possible that early menopause and diabetes work together to increase the risk of CVD in women. And to test this hypothesis, we did a pooled analysis based on 3 cohort studies in US, including the aforementioned ARIC study, and also the MESA study, the multi-ethnic study of atherosclerosis, and the Jackson Heart study. So what we found that early menopause is significant increase the risk of coronary heart disease. The hazard ratio is 1.11. And so more importantly, we found that for early menopausal women with pre-existing type 2 diabetes, their risk is higher than those early menopausal women without diabetes. And this interaction between early menopause and type 2 diabetes is significant. And we also see the similar trend in racial stratified analysis in white and in Black women. So in summary, diabetes and early menopause synergistically increase the risk of coronary heart disease. We also examined the outcome of stroke. Again, we found a similar results with what we found in the in outcome of chronic heart disease. That is, diabetes and early menopause synergetically increase the risk of stroke as well. So we've seen the risk burden of CVD in the postmenopausal women with diabetes. So how about those younger women of reproductive age and those who are still with the cardioprotection from estrogens? So we know diabetes are increasingly common in children and young adults, but the prevalence of diabetes, especially undiagnosed diabetes and prediabetes, have not been clearly described. So we went back to the NHANES data. Remember, this is our largest surveillance surveys in the US. So we generated the age-adjusted prevalence of unadjusted diabetes. And we found it that in contrast to a steady trend of undiagnosed diabetes in the overall population, we're seeing an upward trend of undiagnosed diabetes in premenopausal women in the past 2 decades. And we also found an increasing trend of prediabetes in premenopausal women. So we also examined the metabolic risk factors associated with prediabetes and undiagnosed diabetes in menopausal women using the same source of data. And we compared the magnitudes of association between premenopausal women and their age-matched men, as well as postmenopausal women. So we found that prediabetes is associated with elevated risk of all risk factors, including our study among premenopausal women. And the magnitude of association is apparently stronger in premenopausal women compared to their age-matched men counterparts, as well as postmenopausal women. We also found a very strong association between undiagnosed diabetes and hypertension in premenopausal women. So there are definitely for sure other explanations for these sex differences in diabetic CVD, and this including PCOS, the polycystic ovary syndrome, and gestational diabetes, which are really female-specific risk factors. And there are other research also suggests that women tend to be affected by psychosocial stress and related unhealthy behaviors. And women also tend to be affected by the adverse cardiovascular impacts associated with stress. And notably, women with diabetes also have a higher atherosclerotic risk compared to men with diabetes. So sex differences in non-traditional risk factors such as inflammation, biomarkers, epigenetics, and genetics also play a role in the sex differences of diabetic CVD. So actually in the past decades, genome-wide association studies have increased the number of common SNPs, so the single nucleotide polymorphisms, and to a great extent confirms the relationship between diabetes and CVD. And some new GWAS, the genome-wide association studies, have also found the sex-specific differences in genetic loci that are involved in the regulatory functions of adipose and insulin biology. So I believe with more and more genetic and epigenetic studies, the sex-specific or sex differences of the causal pathway of diabetes and CVD can be further explained. So to summarize, so the excess CVD risk associated with diabetes in women is contributed by poor treatment and management, but also by biological differences between sexes. And women have a greater deterioration in risk factors before overt diabetes. And menopause, especially early menopause, exacerbates the risk of CVD associated with diabetes. And the increased undiagnosed diabetes and prediabetes and the associated metabolic risk factors in women of reproductive age have been underappreciated and suggest the importance of early intervention to prevent or delay the onset of diabetes. And more research needs to be done to reduce this sex disparity. That is, sex-specific biomarkers can be identified for the diabetes diagnosis or prognosis. and the sex differences in causal pathways of diabetes or CVD based on genetic or epigenetic studies also needed, and our public health researchers can design and implement sex-specific interventions for people with high risk of diabetes or for those who are already living with diabetes. So to give thanks to my funding source, the BIRST program, the CaTS pilot programs, who made those works in the sex differences of diabetes possible. And I'm also a member of TCESBM, Tulane Center of Excellence, Sex-Based Biology and Medicine, and also Tulane Center for Aging. And give thanks to my co-authors and Dr. Marvis Jarvis, Dr. Fonseca, and Dr. Anderson, who are my BIRST mentors. And I also want to thank my great RAs, and several of them have graduated, so I'm recruiting new RAs. If you have interest or know somebody have interest in diabetic research, please contact me through email or phone. I'm glad to answer all the questions, or if you have comments, that would be great too.
Absolutely. Thank you, Dr. Yoshida. That was really valuable, incredible information. What insight that you're able to lend. We appreciate it. So as you said, are there questions from the audience? If you'd like to raise your hand, or if there's only one of you with a burning question, feel free to unmute yourself. If you'd like to type it in the chat, I'd be happy to read it for you. All right, well, hearing none, seeing none, unless someone's typing, feel free to keep typing if you are, but I'll go ahead and start our closing remarks just in case. So thank you, Dr. Yoshida, and all of you for joining us today. Again, our apologies that we were a smidge late and in the wrong link, but we'll get it straightened out for sure. Recording of today's session will be available in the next 1 to 2 days, and it'll be shared via the CaTS listserv and posted on the CaTS YouTube channel. So watch your emails for that announcement. We're going to be taking a summer hiatus, so thank you, Dr. Yoshida, for closing out our spring sessions. We're going to be having a break in both July and August, and we'll start back up again in September. So our next CaTS Louisiana Lagniappe Seminar Series seminar should be on Thursday, September 15th, also at 12:30 p.m. So watch your emails for the speaker announcements. We'll be sure and post that as quickly as we know. So, and we are actually also looking for more speakers. Similarly, we are, if you or someone you know would like to share your work, whether it's COVID related, whether it's cardiovascular disease related, whether it's a Louisiana population or not, we would like to hear about it. We would like to disperse your knowledge with our audience. So feel free to reach out to me, Megan Bronson, mbronson@tulane.edu, or Casey Lindsley at Pennington. She's casey.lindsley, LINDSLY, @pbrc.edu. And we'll get you added to our list and get you scheduled. So, but thank you so much again, Yilin. It was lovely having you join us today. We greatly appreciate it.
Thank you, Megan. Thank you, everybody. Bye.
Take care.